All right, we're on the last one. We are going to it wasn't ready. Go over chapter 7, mini number 8. Fractures, types, and surgery. We are going to start getting more into the aspects of OR. So here are the fractures of the hip. I don't need you to know every single name for every single one, but just be aware that there are different fracture locations for the hip based on what it went through. Okay, here's an intratrochanteric fracture, peritrochanteric fracture, and a subtrochanteric fracture. Um, the femoral neck is just this little area right here. Okay, this brown spot right here to the trochanter line. So we have one that is the medial neck fracture, the cervical, which is trans through the neck, and then the lateral femoral neck fracture. So here's the different ways that they can repair hip fractures. We have an intracapsular repair, some nails, and intratrochanteric repair, and here's how you repair a sub, just for giggles. And here's a full hip replacement. So this is what's called a sliding hip screw. Here's the screw that goes into it. And you can see the fracture line. Looks like there was one right there, and there's one right there. See the sharp point right there. This one is an intramedullary nail. Here is the screw part, and then this nail, and here's the side of it, comes all the way down, and it gets screwed into the femur down here. All right. Here's a dynamic hip screw transfixing a trochanteric fracture. And yes, you will see hip fractures on people that have had previous hip fractures before, and the metal is stronger than the bone. Okay, if they fall upon it, it can break again. And here is a bilateral fixation. All right, this poor person, I know. So as you can see right here, this is a total hip replacement where they've screwed the screws all the way up into the wings of the pelvis. This poor person literally has no bony mineralization left. The only thing that they have holding them together is some wire and some screws and some rods. This one over here looks like a younger person because they used a shield and the bony mineralization looks good, but it was probably a traumatic injury simply because half of the pelvis was broke here. This was broken, and they had to screw the pelvis into the sacroiliac joint to keep everything together. So that was probably a car accident. So here is a hip replacement, and this is what it looks like post-op. These are the staples that you can see. What they usually do is they screw the acetabular cup inside of it and screw that into the pelvis. And then here's the ball and the rod that they put into your femur. You can have different variations of kinds. This one is a full-on cup that you can just see perfectly into, and the little screw that's holding it in there. Um, this comes all the way down to the femur. And like I said, if you don't see the end of the rod, you have to shoot another picture. So here's where we're going to start getting into the OR. Okay. I want you to take a look at these tables, and these are usually the different kinds of tables that they use in the surgical suites. So this one, you can see this one has a little head rest right here. So if the patient's head was sitting right here, you would only get to right about here. Okay. Your machine cannot go down further than this. It cannot come in further than this. So if you had legs hanging off the side, you have to be able to know where your machine needs to be, how far up you need to go. Now, if the head was up here, You have legs for days. You can do anything with this machine. And that's usually what they'll do is these things actually come out and you can take this portion out and stick it up here, any various ways. But like I said, you just have to be aware of where the base of your surgical table is. You've got to be aware of your clearance from your C arm to the base of right here. This is a little bit different than this. So you may not have as much clearance between different tables or different OR suites, et cetera, et cetera. So here is the C of the C arm, and I want you to think about where is the image receptor? Is it at the top or is it at the bottom? Where does the radiation come out of? The radiation actually comes out of the bottom. This is the tube right here. And here's a little rectangle looking. This one's actually a little bit smaller, and this one looks a little bit fatter this way than this way. Okay. This right here is an image intensifier. And this one doesn't have an image intensifier, it just has a digital panel. So, what you need to be aware of is when you're trying to come in underneath a patient in a table, how much clearance you have between here and there, which way your tube needs to be, and how are you going to maneuver it around your patient in the OR suite. So here is a C-arm. You need to be able to know the parts and identify the movements. Here is your whole monitor display system. This has 2 screens, usually a keyboard, a printer, and it is hooked with a giant cable about yay thick, but it's about, it's really thick. This part connects to this part over here. And you've got to be careful of those cables wherever they get in your way. You can't go over the cables. You have to go around the cables. So the dual monitor display is best for, last save image, and then you can fluoro or cine or whatever, take another image. We'll go over all that. So what I want you to know is this part right here is the X-ray generator. The big fat wheels right here, they are controlled with these handles. If you push forward, those wheels are going forward. You can turn those handles and the wheels will turn, and then you can drive like this. It's actually pretty cool. This is your horizontal travel. This is your wig-wag brake. And you're like, what the heck's a wig-wag? Well, we'll get there. Here's your rotational joint, which makes your C-frame go either this way or that way. And the C itself, we call it a rainbow, because if you look at it, it looks like a rainbow. You can go rainbow this way, rainbow that way. In all actuality, this is the only free space that you have between the patient and you've got to make room, or you don't make room. It keeps everything together, but you've got to be able to dodge your patient, dodge the table, dodge the doctor, and all that other good stuff. So we will go over the movements here in just a second. I want y'all to watch these videos. This is watching a C-arm. Here is orientation of the images. Now, I think I pulled it on a GE unit, but most units all have kind of the similar language about orientation of images. It's because you need to be aware of how your patient is in the C-arm. If your patient is upside down and this way, you're going to have to orientate your images and flip them so that the physician sees it in anatomical position the correct way. Okay. This right here is something you might want to take a look at. It's like a 25-minute video. It's called Mastering the C-Arm by a radiology coach. And he gets you more familiar with the things that you can and can't do with a C-arm. Here's the different collimations that you can use on different collimators. There's the iris, which is like the iris of your eye. It closes in a hole. And then you have linear collimators. Now, I'm going to tell you right now, using a C-arm is way different than using an X-ray machine. Most C-arms that I have seen do not have the availability to change your technique. You can only either go up or down in kVp. You don't have the ability to change any more mass or any less mass. You can tell the machine that you're taking an image with metal in it, and it will compensate for that. But you can't, if I need to reduce my kVp, the entire technique will reduce. Okay, so we need to get familiar with that and the reasons behind that. So for a hip x-ray, and I don't want y'all to be scared, but I want you to be prepared. Okay, a hip x-ray it's a big deal. Hip x-ray is one of the most sterile procedures that you will ever encounter in your entire life. So some of the things, if you're in there before surgery so that you can prep and see what's going on, is the patient will be asleep. They will start, the doctor will come in and make their notes. They will find their landmarks and their positions, and they will, mark out what they're doing. They make sure that they have the right side. So a patient gets put on a table, and I want you to see this one right here. It almost looks like a spine table, but there's a rod going down here and there's a rod coming here. And the patient's literally, the edge of their butt is right here. And then there is what's called a perineal block where their legs are spread and the patient is pulled down all the way up to that. Like here's a big foam wedge right here to try and protect, vital organs and parts. Because what they do is, I want you to take a look here. You see this foot? It is wrapped in Coban, just like this one over here. They are wrapped in Coban and they are put into a little boot. And I have a picture of it later. And those legs are put into traction. All right. So, here's one with traction. This one is pulled this way, and this one is obviously pulled down. And here you can see that the C-arm is lined up. Not right now, sweetheart. The C-arm is lined up in a lateral right here to look through the femur. Sweetheart, I need you to go do it over there. Oh, thank you. Okay. So here is an interesting thing with two C-arms. You can see this C-arm right here, and here is another C-arm over here. And yes, this does happen sometimes. Sometimes they'll use a mini and a big C-arm at the same time. It's pretty cool. Here's ankle surgery, because you need to have a big C-arm to get into any bone that's bigger than the midfoot. Okay. The mini C-arms you can use for fingers, toes, foot, hand, wrist. But anything bigger than that, then they like to use the regular C-arm. Now, here is another fella who is wrapped up and his legs are being pulled apart and he's in traction, because when they cut into him right here, they want to have that bone pulled apart so that they can get in and do the surgery. So you can see right here, this is the left hip, and that is the one that has been marked yes for surgery. And you can see that the C-arm is on the right-hand side. For major surgeries, you have to be on the opposite side of the surgery. This right here, I can tell you that is the right foot, and the C-arm is on the right side. Okay, this is the left hip, and the C-arm is on the right side. The reason for that is This machine is huge. Okay, your physician and your physician assistant is going to stand right here. Sorry. They're going to stand right here and they're going to be performing surgery. Then they'll ask you to come over and take a picture. They can't get out of the way. You're going to have to come in on that side. So here's another position that shows you the traction that is applied so that they can get in there and do what they need to do. These tables are really kind of cool and unique that they can turn the patient's foot out, or they can, rotate it medially or laterally, however they need to do it, depending on the fracture. Okay. And that's the end of that. That is mandatory to go and watch those videos so that you can become more familiar with a C-arm, how to move a C-arm, how to orientate the images, and go ahead and watch Mastering the C-arm by the Radiology Coach. Okay? That's the end of the chapter.